morning, everyone. It is my utmost honor and joy to present this webinar on the American College of Lifestyle Medicine's clinical practice guidelines for lifestyle intervention for treatment and remission of type 2 diabetes and prediabetes in non-pregnant adults. So without further delay, I'm going to get started. I do not have any conflicts of interest to disclose. The objectives of this webinar: understand the purpose and structure of the American College of Lifestyle Medicine Diabetes and Prediabetes Clinical Practice Guidelines, explore key action statements and the evidence behind them, learn how to apply the CPG, the Clinical Practice Guideline, in clinical settings. What is a clinical practice guideline even? Okay, so these are systematically developed statements intended to assist clinicians and patients in making decisions about appropriate healthcare for specific clinical circumstances based on a rigorous review of available evidence, predominantly focusing on high-quality evidence from systematic reviews, meta-analyses, and randomized controlled trials. So they are meant to serve as a decision-making support to help clinicians and healthcare professionals, as well as patients, to determine optimal approaches and to avoid or reduce ineffective or harmful care options. By providing a standardized framework, they aim to reduce redundant variations in care and help empower patients and healthcare professionals, also known as HCPs, plus provide a broader policy framework for payers and systems. So during my webinar, you'll hear me say the word systematic or standardized or structured a lot. Because that is what is the purpose and intent of the CPG. Purpose and vision of this CPG: provide actionable guidance to any clinician or HCP in a community or outpatient healthcare setting involved in managing non-pregnant adults with type 2 diabetes, prediabetes, or a history of gestational diabetes, also known as GDM. Now, we want to emphasize this is outpatient only, so we are not really intending for this document to serve in an inpatient or a subacute rehab or a nursing or skilled nursing facility. We want to promote standardized and lifestyle-focused clinical care, and this aligns with the ACLM vision of root cause resolution. So, throughout this document, we want to present a paradigm of, guideline-directed lifestyle therapies. Some of you all may have heard from cardiology literature the phrase guideline-directed medical therapy, or GDMT. And, it is very highly evidence-based, kind of a structured paradigm of having the timely and relevant, proven medical therapy, whether that is beta blocker or ACE inhibitors or SGLT2 inhibitors, for patients who have cardiac problems, whether that's coronary artery disease or heart failure. In a similar format, we want to present the paradigm of guideline-directed lifestyle therapy, which is really strongly evidence-based and encompassing all the 6 pillars of lifestyle medicine, not just nutrition or physical activity or long-term behavioral change, but also focused on connectedness or avoiding risky substances or behaviors, or managing stress in a positive, stress resiliency focus, and then of course focus on sleep patterns or sleep quality or sleep quantity. So that is the purpose of this CPG. This is our team of illustrious authors. I was honored to be the corresponding author and the co-chair of this document. Our chair was Rich Rosenfeld, our methodologist, and we had a really truly stellar team of staff, including Michaela Carlson, the director of research, and Kara Staffier, the associate director of research. My co-chair is also Megan Grega, and then we had really, an incredible team of different multidisciplinary stakeholders from various medical societies. And I think that is one of the biggest strengths of this document, that we have uh, really a diverse array of specialties represented, whether that's physician associates or nurse practitioners or Academy of Nutrition and Dietetics, the American Academy of Family Physicians. We had the American Academy of Sleep Medicine, Sports Medicine. We had clinical pharmacologists on board. We had, of course, the American Association of Clinical Endocrinology, Dr. Valencia, who was also our co-author, and then really an incredible spectrum of voices, including consumer advocates. We had two consumers or end users. So this became a really, a wonderful assortment of voices and expertise from really all across the healthcare landscape. That is our team. We had a total of 3 conference calls and 2 in-person meetings. This is one of those in-person meetings in January in Pennsylvania. Are endorsing different medical societies. We have a total of 8 organizations who endorsed this clinical practice guideline document, and then another, support by the American Academy of Nutrition and Dietetics, and affirmation of value from the American Academy of Family Physicians. And as you can see, really wonderful layout of all the different medical societies, including endocrinology, obesity medicine, health and wellness coaches, sleep medicine, diabetes care and education specialists. So, really a document that comes from a lot of expertise across the board. So endorsements matter because we are talking about interdisciplinary support, and we all know that diabetes and lifestyle medicine both are team sports. We need different professionals and all hands on deck. So this is, it builds institutional and clinical credibility. We are strongly evidence-based from all different walks of life, and it encourages adoption across different care settings. So why are we focusing on diabetes and prediabetes? What is the global burden? It is a defining disease of the 21st century. The World Health Organization had set out for a target in 2013, that by 2025 there was a call to action about halting the rise in diabetes and obesity. And of course, that has not unfortunately happened. We now stand at almost over 800 million people across the world already with type 2 diabetes. That's close to 1 billion. And we will definitely have more than 1 billion people expected to have diabetes by 2050. Projected cost of type 2 diabetes, at least $1 trillion, perhaps more. About half of US population either has diabetes, that's approximately 13 to 14% by different estimates, and then pre-diabetes about 37%, so more than 1 in 3 American adults. And that makes up 25% of total healthcare dollars. So 1 in 4 healthcare dollars for this condition. And here is the kicker. 80% of all type 2 diabetes is preventable with lifestyle therapy. So this is a giant that does not need to exist. And we had the diabetes prevention program published in New England Journal of Medicine in 2002. That was almost 23 years ago. And here we stand with really unprecedented numbers of diabetes and prediabetes affecting younger and younger populations. And this is a worldwide phenomenon. It's of course, a big problem in the US, but also globally. So unique value of ACLM's guideline on type 2 diabetes. This is why do we need another guideline? It is a 238-page document focused only and exclusively on lifestyle therapy and on all 6 pillars of lifestyle medicine. So this is purely lifestyle therapy. We do not delve into pharmacotherapy or surgical therapy for these conditions. They have their own place and value, but our goal was to focus predominantly on the primary therapy for diabetes and prediabetes, which is lifestyle. It distinguishes between and provides a systematic framework for treatment versus remission of type 2 diabetes. It builds on the multidisciplinary consensus from diverse stakeholders. It enables depth and breadth of this therapeutic nuance to the application of lifestyle therapy, guideline directed lifestyle therapy. So, really focusing on structured treatment algorithms. There are 30 figures and 30 tables to help guide the busy practicing healthcare professionals in their day-to-day practice and pragmatic decision making. Our intent is not to, have like a full sort of a comprehensive summary of how to manage prediabetes or type 2 diabetes, and it is not intended to replace other guidelines. We focus only and explicitly on lifestyle changes, and we are excluding other information like how to diagnose diabetes or how to prevent type 2 diabetes, the medical treatment or pharmacotherapy, dealing with micro and macrovascular complications, because those are extensively dealt by other guidelines. The value of this CPG document lies not so much in its novelty, but in its granularity and in its real, focus. One last point, this also hopefully serves to combat or address misinformation and disinformation. When it comes to lifestyle therapy, there are all kinds of misinformation floating on the internet, whether that is, we keep hearing about things like seed oils or red meat or saturated fats. And, this guideline, hopefully, because it is so multidisciplinary and comes from various medical organizations and stakeholders, really aims to lie to rest many of these aspects that our patients are routinely exposed to, and even our healthcare professionals are routinely exposed to. So making it easier for all stakeholders to kind of sift the noise from the actual evidence. We stuck to the well-established methodology, well-validated. This is from the Oxford Center for Evidence-Based Medicine. This kind of lays out how do we assess the aggregate grade of evidence or the strength of evidence. Grade A is when we have really unequivocal evidence from systematic reviews or even meta-analyses of randomized interventional trials. And then grade B would be when you have randomized controlled trials or observational studies with dramatic effects or highly consistent evidence, right? So in general, in a clinical practice guideline, we try to stick to make recommendations only on grade A or grade B evidence. And that's what we tried to do here. We had maybe a little bit of grade C evidence when it came to our last key action statement number 14. But otherwise, we really wanted to stick to only grade A or grade B high quality evidence. And this is where we come to how strong is our recommendation. So we give it a strong recommendation if it is based purely on unequivocal grade A evidence in terms of the preponderance of benefit over harm. And 12 out of 14 key action statements that we made were strong recommendations. Now, they were based on either grade A or very strong grade B evidence with a, very sort of what the guideline committee deemed very important high quality grade B evidence. So, we can do strong recommendation on either grade A or grade B, and that's what we did for 12 of our action statements. The remaining 2 were recommendations. And I'll tell you which ones were recommendations but not strong recommendations. So we began with, and I will not belabor the methodology, but we began with, I think we had, over 1,000 initial search results, and then we narrowed those down to 294 studies. And then the co-chairs, me and Dr. Grega, and our chair, Dr. Rosenfeld, we narrowed it down to 126 systematic reviews, 107 randomized trials, 8 guidelines, 6 umbrella reviews, 55 observational studies, and then 14 review or consensus sources. I also want to shout out to the American Diabetes Association Standards for Medical Care, the 2025 and the 2024 documents. And so, as you can see, really a very rigorous, in depth and in breadth, we had really a very huge sort of the quantity of literature to sift through. And we began this process of starting the guideline in summer of 2023. So this has been almost a project of 2 years. The components, we began with the introduction and background, the burden of diabetes and prediabetes, the epidemiology, the sort of the cost analyses, etc. We have 14 key action statements that I will lay out in the next few minutes. We talked about the implementability and research needs, and then we have, what really stands out in our document are extremely user friendly, very design thinking oriented uh, tables and figures, and of course there are hundreds of those references at the end of the document. So what is an action statement? What goes into recommending something strongly, or recommending kind of a action in a document, in a clinical guideline, right? So we want to base it on a quality improvement opportunity, a very structured recommendation that this is what we recommend based on this aggregate of evidence. And then we lay out how what's the grade of the evidence and how strongly we are confident in that grade of evidence, right? And then we lay out some value judgments based on the committee's inputs. We talk about patient preferences, and then we lay out the implementation insights. Let me give you an example, and I'll begin with statement number 4 instead of statement 1, 2, and 3. And that's because I'm going to begin with something which is very non-controversial, which is the importance of physical activity in diabetes and prediabetes. So that's our statement number 4. We call it CAS, Key Action Statement. And this basically is a statement on prescribing aerobic and muscle strength physical activity. So the HCP should prescribe physical activity with an emphasis on aerobic and muscle strength training by establishing SMART goals, which are specific, measurable, achievable, relevant, and time-bound goals using the FIT framework, the Sports Medicine College, the FIT format, which is the frequency, the intensity, the time, and type of physical activity, right? So the frequency, how many times each week, is it 5 days of the week, and the intensity, is it moderate intensity, the time, which would be 30 minutes or 150 minutes in a week, 30 minutes each session, and the type, aerobic, or are we doing 2 sessions of strength training or resistance training? So really giving that framework to the clinician for implementation. For adults with, of course, our population through all of this is going to be non-pregnant adults who have either type 2 diabetes or prediabetes or a history of gestation, right? So that was our succinct key action statement. It is a strong recommendation, and it's based on really a wealth of grade A evidence. It's based on, systematic reviews, and there's a huge preponderance of benefit over harm. This is the number of, studies that we found, and they enumerate the benefits of regular physical activity for individuals with these conditions. So we also talk about, the benefits, the risks, the costs, and the value judgments. Our committee, it chose to emphasize aerobic and muscle strength training because they align with the physical activity guidelines for Americans, the federal guidelines, and they're most evidence-based. But we also recognize that there are other modalities, whether that is balance training or yoga, or there is flexibility training, etc. So, that kind of comes into the value judgment. So that is the anatomy of a key action statement. I also want to quickly enumerate all the key action statements that we have in our guideline document. These are the first 3. So the first key action statement is we want the healthcare professional to advocate for lifestyle interventions as first line. I repeat, first line therapy, and that includes all the 6 pillars, beginning with sleep, stress management, and of course physical activity, connectedness or positive social connections, whole food, that is whole or minimally processed, unprocessed food, plant predominant eating pattern, and avoiding risky substances. So we want our HCPs, the strong recommendation is that HCPs should be an advocate for lifestyle therapy being the first line therapy, right? And that is obviously not a controversy. The second key action statement is assessing the baseline lifestyle habits of a patient or a consumer, educating the consumer regarding the opportunities to improve their lifestyle behavior, and evaluating the patient's readiness to change. And that readiness to change is really paramount. So again, not something controversial or confusing. And then this one, I think we're really proud of this, establishing priorities for lifestyle change in a shared decision making format. And throughout the document, we are very clear that this is a shared decision making process because this comes from a committee that has the sort of the design thinking with the consumer in mind, and we have consumer representatives on this panel. This is kind of a co-creation of a therapy with the clinician and the end user or the consumer really kind of deciding what works in terms of therapeutic efficacy. And discussing the role of really goal setting, SMART goals, specific, measurable, action oriented, relevant or realistic, and time bound goals in supporting positive lifestyle change. So that's the third key action statement, really prioritizing and having a priority plan. Whether that is a patient's goal to, if they are dealing with a lot of stress right now, they have 2 jobs and barely enough time to breathe. They don't have time to cook, right? Or they are dealing with other stressors, whether that's related to having stable housing or a stable food environment, etc. So truly discussing and co-creating a goal for what would be their priority, keeping their priorities, their purpose, and their personal values in mind. So the steps are their the goals that they lay out for themselves with that vision. These are the two sides of the ladder. And I think the ACLM team, the graphics design, did an extraordinary job creating these different figures and resources, which are going to be available to all. This is basically going to be part of the document. There will be actually a guide, a pocketbook, or even I don't know if we'll have smart cards, etc. But these are amazing resources that clinicians and healthcare professionals can utilize in their day-to-day practice. They are immediately relevant and readily adaptable. So that kind of is how the key action statements are framed. Now, in terms of assessing their baseline lifestyle habits, we have enumerated all the different validated assessment tools. So these are again available to our consumers and our clinicians. This is our key action statement 5. Sorry to kind of go back and forth, but this kind of follows from the statement number 4, which was to prescribe physical activity. This focuses on reducing sedentary time for our target population, right? So again, it is not just about moving more, it is also about sitting less. And this was something that the Guideline Committee felt is extremely important in terms of educating patients about that. Every 30 minutes, patients should stand up or do some kind of movement, just because of the preponderance of evidence on harms of sedentaryhood and increasing overall skeletal muscle deployment, right, to mitigate hyperglycemia. So moving on, again, beautiful graphic resources on how we can prescribe snacktivity, exercise snacks or bite-sized exercise, marching in place while, we're standing for something, let's say, food is heating in the microwave, or, there is some printouts going on at the printer. Can we utilize that 1 minute to do some either lunges or squats or marches, stretching, step ups, right? So really encouraging minimizing sedentariness in patients with prediabetes or diabetes. Statement number 6 is based on sleep. We should be asking. So this is an asking statement about the quality, quantity, and sleep pattern. and then determining if they have a sleep disorder, like if they have obstructive sleep apnea, if there is a risk for shift work disorder, or chronic insomnia, primary insomnia, or restless leg syndrome, etc., then refer accordingly to a professional for further evaluation and management, referring to sleep medicine experts, right? Or chronic short or long sleep duration, etc. So, recognizing what kind of sleep disorders can be disproportionately higher prevalence among our patients with diabetes. And these are the, again, grade B evidence, but strong recommendation nonetheless, based on the preponderance of benefit over harm. Statement number 7 is focused on nutrition plan for prevention. So we were again very proud of actually really delving into the distinction between preventing diabetes or treating diabetes, improving diabetes, versus actually remitting diabetes. And this is based on, the sort of the different evidence elements available for each one of those prescriptions. So again, the other very important aspect of this was we prescribe a nutrition plan that is culturally rooted or culturally tailored. It's kind of based in the foundationally in the patient's cultural background, and it is food based and not nutrient based. So we are not prescribing a plate that comes from a certain percentages of carbohydrates or fiber or protein, but really based in foods, whole food, whether that is vegetable based or fruit based or legume based or whole grain based. And it's a strong recommendation based on grade A evidence. The value judgment here I want to emphasize is a perception among the committee members that the importance of history of gestational diabetes is underappreciated as an opportunity for nutritional intervention. And we really found scarcity of, adequate resources applied to or literature studying women who had history of gestational diabetes, even though it's a much higher risk factor for developing type 2 diabetes than even pre-diabetes. And this is a young population, and the prevalence of gestational diabetes is truly exploding. So keeping that in mind, we think applying this statement, this recommendation is extremely vital and crucial for all patients who've dealt with gestational diabetes. And then, we have excellent graphic resources and figures and tables for consumer use, for healthcare professional use. Statement number 8, again, it's a wonderfully nuanced. This one, we really want to clarify with our consumer, with our person who's got type 2 diabetes, their goal, really co-creating a goal or shared decision making on if the goal is to achieve type 2 diabetes remission or type 2 diabetes improvement, right? And of course, it can depend on the duration they've had the diabetes for. But really, clarifying it with the patient, and because, the lifestyle therapy, really the dose of lifestyle therapy will depend on whether the goal is remission or just improvement, right? And remission requires more intensive lifestyle efforts. So again, value judgment on that. I will not belabor that. Excellent graphic resources. This one comes from the Ardmore Institute of Health. But really focusing on moving from processed foods to more whole unprocessed foods with higher fiber, moving from refined or simple carbohydrates to complex carbohydrates and more vegetable forward plates, right? And then we move on to statement number 9. This is a strong recommendation on connectedness or social support, which ends up being the number one actually determinant of successful maintenance of remission. So data from direct trial from the UK as well as multiple other weight loss registries suggest that family support is the biggest determinant of somebody being able to maintain their diabetes remission. In fact, in the direct trial, the patients who successfully remitted their diabetes, their spouses also lost a significant amount of weight. And so having that connection, having that supportive fostering environment for our patients can be a huge, actually the hugest factor in their health outcomes, not just diabetes remission. So we have a statement, a very strong recommendation on that in our statement number 9, that the healthcare professional really should be engaging with the patient, that this is a counseling statement, that we should counsel our patients regarding the importance of cultivating that support system, right? Recognizing that support system. So let's say if I'm a healthcare professional prescribing lifestyle therapy in my clinic, my first step for my patient with diabetes is not, okay, what nutrition plan are you going to embark on here? Have this many calories or go on Mediterranean diet. But to list down, to jot down, exactly who are the support system that they are enlisting in their in their notebook or in their diary. Who are the people they call when they are feeling stuck, right, or feeling like they need support or need some help along the way. Having that support system, enlisting that support system is an important um, priority for diabetes optimal management. Um, so again, the value judgment, this connection pillar may be underappreciated. I think every listener on this webinar may perhaps agree with that. But a very under-recognized influencer of our health outcomes. Statement number 10, this is a recommendation. This is one of our 2 statements that is not a strong recommendation, but a very, important recommendation nonetheless based on grade B evidence. And the statement is that we should be, assessing for identifying, major stressors or mental health aspects, whether that is mood disorder or anxiety disorder, and then prescribing or referring appropriately in each circumstance, whether that is a mindfulness based cognitive behavioral therapy support or other behavioral health modalities, right? So have at the background of all of our patients, if they are suffering from major diabetes, distress, or other anxiety, really having, identifying that in our clinical encounters is an important aspect. And this is not unusual. The American Diabetes Association concurs on this one. Statement number 11, it's a strong recommendation, assessing our adults, through all those different assessment test that I had previously laid out in statement number 2 was, assessing for use of troublesome alcohol use or tobacco or other recreational drugs, because that can absolutely impact the quality of diabetes or pre-diabetes control and outcomes. These are the screening tests again. This one is particularly for alcohol. And these are the summary of all the statements that I said so far. So now I go on to the last 3 key action statements, because I do want to talk a little bit in depth about the statement number 14, which is going down on pharmacotherapy systematically as we go up on lifestyle therapy, right? So statement number 12 is sustained positive behavior change. So as you remember, statement number 2 was indeed about assessing somebody's baseline habits. And statement number 3 was to set up a goal plan and a priority plan, right? So that is establishing the plan. And then this one is really tailoring and creating a sustained kind of a longitudinal plan where the patient has, kind of a clear roadmap of the journey. And this would also include all the different evidence-based approaches from behavioral health literature, whether that's coaching, whether that's motivational interviewing, cognitive behavioral therapy. And we had a lot of wonderful support from our health and wellness coach colleagues and our psychology colleagues to frame this document and this recommendation. So really laying down that plan right off the get-go. Also continuity of care, which is part of the conversation, establishing, exactly the frequency of visits, whether that's going to be telehealth visit or in-person visits, duration of care, so is this a 14-week intensive plan where we are exclusively focusing on diabetes remission, or is this a 1-year plan and we are focusing on how to prevent type 2 diabetes, and it is going to be, sort of a more the less intensive but more sort of structured and long-term plan for maintaining remission, etc., right? So kind of finding out how much of the need for decreasing pharmacotherapy would be, laying out those expectations on what the patient's intended frequency of visiting in person or visiting on telehealth would be, what is the expectation regarding their engagement, right? And then statement number 14, we really wanted to give a recommendation. This is not a strong recommendation because we don't have grade A evidence, but really creating a recommendation on how we can adjust the dosing and the type of a patient's pharmacotherapy. And we only talked about diabetes pharmacotherapy. We did not talk about hypertension or lipid lowering therapy based on the impact of lifestyle intervention on their medication needs. So I wanted to particularly go into the details of the statement number 14, right? So we created at least 3 different tables or figures, I should say, not tables, on how we can assist our clinicians or clinical pharmacologists or clinical pharmacists in empowering a patient as they are embarking on a journey of particularly, let's say, type 2 diabetes remission and they are doing intensive lifestyle efforts. If they are on medications that are frankly associated with hypoglycemia, that would include sulfonylureas and insulin. And then some patients are also prescribed meglitinides like repaglinide. So these are non-sulfonylurea insulin secretagogues, and they can all be associated with severe hypoglycemia or hypoglycemia with numbers less than 70 milligrams per deciliter, the glucose values, and that can be dangerous acutely for a patient, right? Especially if it happens in the middle of the night. So if somebody is embarking on intensive lifestyle, even if their sugars currently are very high, we did want to say, if possible, get rid of the hypoglycemia causing drugs, if that is possible, or at least decreasing the dose. And then, with insulin, if they are embarking on intensive lifestyle therapy, then they may need at least a 10% decrease in their insulin dosing if they're running high currently. If their sugars are not very high, if their glucose is consistently less than 150, then if they embark on intensive lifestyle therapy, they're clearly at a very high risk for hypoglycemia. So in that case, we want to substantially decrease their insulin dosing, maybe at least 20 to 40%. And patients who are on insulin, we strongly recommend, like all the other medical societies, including ACE and ADA, the American Diabetes Association, we strongly recommend using continuous glucose monitors because they have built-in hypoglycemia alerts. We would prefer for that to be available even for patients with who are on sulfonylureas. Again, ideally, we're getting rid of sulfonylureas right off the get-go in patients who are embarking on intensive lifestyle therapy, if that's possible. And then we want to consider switching to insulin analogs, which are associated with a decreased risk of hypoglycemia compared with NPH insulin, which is perhaps a little bit more associated with nocturnal hypoglycemia. So insulins like degludec or glargine. Now, detamid is no longer available in the market, but glargine or degludec may have a little bit of a lower risk for nocturnal hypoglycemia compared with NPH insulin for patients for who that's an option. Of course, that may not be feasible for patients who don't have the type of insurance to be able to get these basal insulin analogs. Some of these can be prohibitively expensive. So that is again very granularly detailed in our key action statement on how when patients embark, particularly if their goal is diabetes remission, they are embarking on perhaps initially a very calorie reduced plan. In the direct trial, patients were not on insulin, but they had relatively recent onset type 2 diabetes, and they did go on a very low calorie diet plan in the first 8 weeks or 12 weeks. So their medications were completely stopped right off the get-go. Any diabetes medications, whether that was sulfonylurea or metformin, were stopped right away. We would strongly recommend stopping sulfonylureas if patients are embarking on something very intensive or even relatively less intensive when we anticipate that they will have a calorie deficit of 500 calories or so or thereabouts. The non-hypoglycemia causing drugs, especially if patients are not embarking on very intensive lifestyle therapy, there is relatively less risk of hypoglycemia here, or possibly close to almost none risk of hypoglycemia here. So those drugs, it's not that urgent to stop them right off the get go, unless if they are really adding to costs and polypharmacy and complexities and burden, in which case start with the drugs which are not very well studied to affect cardiovascular outcomes. So we know that DPP4 inhibitors like sitagliptin or um, linagliptin, they are not really that strongly associated with cardiovascular improvements or mortality improvements. So it is easy to give those up. Acarbose, again, not very strong data of cardiovascular improvements. We can stop those easy. The rest of them, particularly metformin, which is very inexpensive. The GLP-1 receptor agonist drugs, these are the newer drugs, the twin incretin drugs, the GIP and GLP-1 receptor agonist medication, which is tirzepatide. This class of drugs, is strongly associated with major adverse cardiovascular event outcome reduction. So MACE risk reduction to the tune of 15 to 20% in some studies, right? So these are associated with positive outcomes, including all-cause mortality or at least cardiovascular mortality. And we have to be careful if a patient already has established cardiovascular disease or they have a history of stroke or MI, then we may not want to stop these drugs or continue these drugs at a lower dose, unless if there are, patient strong preferences or if they have adverse effects from these drugs, in which case it can be stopped, right? But if these are being taken for mortality risk reduction and for secondary prevention, then we don't recommend stopping them. Or if they have chronic kidney disease, to avoid, progression to end stage kidney disease or dialysis situation. So if they are using it for established diseases, in those circumstances, it may be best to keep them going or de-escalate the dose, unless if it is cost prohibitive. Same thing for SGLT2 inhibitors. These drugs are very strongly associated with reduction in mortality or MACE and kidney outcomes. So if patients are already, if they have established kidney disease or heart disease, then be careful in terms of stopping these classes of drugs, the GLP-1s and the SGLT2 inhibitors. Thiazolidinediones, they can be stopped safely in many patients, unless if somebody has a history of stroke, in which case this may help. But again, they do not need to be continued indefinitely if a person's goal is to de-escalate and de-intensify their polypharmacy and cut back on the burden of medication. So I think we have covered the basically the nutshell of the entire CPG document, all 14 statements, and we have belabored the statement number 14, which is really which was a demand from our college members, in that everybody wants a nuance to how do we medically manage people's pharmaceutical burden as they are embarking on lifestyle therapy. How do healthcare professionals do that in a systematic and structured format? And we have multiple other resources that our members can utilize, whether that is our diabetes remission certificate course or our food as medicine for type 2 diabetes remission course, which is a 3-hour CME. That the certificate course itself is 18-hour CME. We have the LEADER project, which we are actually looking for health systems to adopt. This has been developed by Dr. Carlson, Michaela Carlson, the director of research, and they've got this incredible program that is readily utilizable and implementable in a clinical setting. So if your practice is interested, please reach out to the research department, to Dr. Carlson's team. And I would end this webinar with our key takeaway points and also a vision for the future. What are the goal from this guideline document is, and what I envision for our future guideline document, when we revisit this in 5 years' time. where would I like more research on, or which direction I want this roadmap to go in the future. So with this, we set out to create a very pragmatic, a crystal clear, action oriented and implementable document, a CPG document that would be immediately relevant to your healthcare landscape and your day-to-day practice beginning today. We wanted to create a proposal for a structured, systematic, evidence guideline directed lifestyle therapy. And this is a framework that opens the door not just for type 2 diabetes or prediabetes, but all the other chronic conditions that are basically 90% of our healthcare GDP, our healthcare budget, and 80% of all healthcare today in the US is chronic conditions, whether that is cardiovascular disease or cancer or obesity or hyperlipidemia. This kind of opens the door for having that, framework implementation conversation in all aspects and that touch every single healthcare professional. So the 6 pillars of lifestyle medicine are key, but equally important are the statement number 1, which is healthcare professional advocacy, the statement number 2, which is assessing a person's baseline or their readiness to change, the statement number 12, which is sustaining that change, having that well laid out roadmap, and statement 13, which is continuity of care and engaging the patient and healthcare professional on a sort of a very mission oriented path where they hold hands together and walk this journey together. And then the vision for the future, I think, we want to bring in more design thinking with, the end user in mind, really harnessing the system strength. We want to use advanced tech tools, including AI. Where would habit science, the literature around habit design, role of social media is going to emerge. I think that will be the bane of our generation, addressing misinformation and disinformation. I think that will be a huge part of the future frameworks. How do we create, sort of this format where the users, the consumers know the right information that comes from actual evidence? And how do healthcare professionals help our patients navigate that in this complex environment, right? Where, there is no dearth of or no scarcity of wrong information floating around. So with that, I wanted to shout out to all of our amazing guideline committee, our development group, and sincerest gratitude, heartfelt gratitude, and what a tremendous, mission-oriented, seriously, sort of a heartfelt work. Thank you to all of you for listening.